America is home to 33 million small businesses, the beating heart of communities across the country.
And proof that the American dream is still alive.
This is a show about those dreamers and doers and the communities they serve.
Their real life stories.
Their struggles and successes.
Their grit, determination, and passion.
And the people who fight
to keep their American dream alive.
I'm Alfredo Ortiz.
I'm Elaine Parker.
And it's time for another episode of Main Street Matters,
America's small business megaphone. Hi, and welcome to another episode of Main Street Matters, America's small business megaphone. I'm Elaine Parker, the president of the Job Creators Network Foundation.
And I'm Alfredo Ortiz, the CEO of Job Creators Network.
Please subscribe to the show at salempodcastnetwork.com or wherever you get your podcast from. Well, Alfredo, today we are going to be joined by Dr. Molly Rutherford. She is the founder and medical director of Bluegrass Family Wellness Clinic in Crestwood, Kentucky. And she has over 20 years experience in the medical field. She's also been an advocate for healthcare reform that's rooted in free market. And as you know, we met her when she worked with us about 4 years ago now, I guess. It's amazing how time flies, on our campaign, Healthcare for You, which was the counter argument to Medicare for All. And what I love about Dr. Rutherford and doctors like her is they come to us with such a unique perspective about healthcare because they are doctors, they are patients themselves, and they're small business owners when they have their own practice like this. So they really have a perspective that I think is so powerful. Alfredo, we've also seen just average healthcare premiums skyrocket under Obamacare. I mean, the premiums for families have risen 174%. It's outrageous. I don't know how middle-class families do it.
Yeah, they don't. And small business owners, I mean, we really still haven't found a solution for small business owners. I know Secretary Alex Acosta, when he was a labor secretary under Trump, was trying to get through the association health plans. And that unfortunately didn't get through because of legal challenges. But we do have to find a solution for small businesses still.
Yeah, that was, and that could have been a real game changer, the association healthcare plans. But let's talk a little bit about Healthcare for You before Dr. Rutherford comes on with us, because she can kind of take our policy ideas and bring real world experience to it. So Healthcare for You, it stems from a study that you put together when we were working closely with Physicians for Reform. 25, probably the largest healthcare study of that I'm aware of. 25,000 American voters, and we surveyed them to find out what was important to them in healthcare choices, and what came back was interesting: the doctor-patient relationship, getting bureaucrats out of their decision making and making these decisions between yourself and your doctor, and creating more choice and competition, which means what? Free market, right?
Yeah, that's right. That's right. And it was actually pretty interesting because it's something that I pulled from my old consumer product goods days, in which we tried to identify how we would roll out different products and product lines. And for all the nerds out there, it's called discrete choice modeling, but it basically puts one benefit against the other and makes you choose between them. And ultimately, you have a list of prioritized benefits based on this discrete choice modeling. And then you put price points on it. So if you ever wondered, for example, how people or how auto manufacturers, for example, put together three different styles of cars, the XLS, the XL, and the L, let's say, and which options go with which, they use discrete choice modeling to do that. So we use that same theory and that same application, in this case, to come up with pretty much an optimum healthcare plan, which at the end of the day in testing scored better than Obamacare.
Yes, but the interesting point that I love when you talk about it is that that popular element of Obamacare, which is keeping kids on your plan until they're 26. Tell our
Right.
listeners a little bit about how that scored.
Yeah, I mean, on a just basic poll, what most of DC uses, that particular benefit of keeping your kids on your plan up until they're 26 scored super high, right? So nobody wanted to touch it in terms of getting rid of it because it scored so high. But if you actually do a discrete choice modeling like we did, it actually scored almost at the very end of a list of benefits, because when people are really asked to choose between one or the other, that really wasn't as important as many of the other benefits that fell before it. And so it's a great way of actually truly doing research development and product development. And but that's one that has a lot of cost if you think about it, because keeping your kids on the plan for 20 till you're 26, there is a tremendous amount of cost there because, for example, females, a lot of them are having children by then. And so there's a big component of that your average actuary would go through and calculate, and that's part of the cost. And so eliminating that out of the plan is actually not an unpopular thing and brings down the cost of the overall plan.
Exactly. Yeah. Well, some of the elements. So what we did was we created healthcare for you, and I love the tagline on it. It's personalized healthcare, your health, your doctor, your wallet, your choice. It's the antithesis of Medicare for all, which was, it's saying to me that it was for me and my family.
Right.
But we created this framework of healthcare, of elements that were important based on all of that research. And of course, number one, above anything else, was protecting those with pre-existing conditions. Can't argue with that. That's very important. Number two was lowering insurance premiums through increased choice and price transparency. I mean, talk about that, Alfredo. Price transparency. I imagine that competition.
Yeah, I mean, it's as with anything in the free enterprise system, competition really actually leads to lower prices. And that's actually, if you think about it, something that doesn't exist in our healthcare system today is true competition, because there's so much government control. And in fact, if you take a step back and think about what are some of the largest issues in our country that exist, like education and healthcare, it's because there's so much government control in the system that there's not an ability to have free enterprise. If we take a quick path over to the education side and we think about what's going on with school choice, that's actually providing competition within the education system to hopefully not only bring costs down, but to improve the quality of the delivery of the service. Very much like what we would be doing in healthcare, where you introduce actually the free enterprise system into healthcare so that you can actually have competition for the best care at the lowest cost.
Exactly. And some of the ways that we did that by working with organizations like Physicians for Reform and doctors like Dr. Rutherford is through direct primary care, direct medical care. And those are physicians who have taken themselves out of the insurance system, and they've moved to basically direct pricing. So you can go to a physician, and it's kind of like a gym membership almost, and you pay a set fee every month. And that encapsulates all of your primary care needs, basically. Whether you go 20 times or one time or no times, it's like a gym membership. And it allows you to have that patient-doctor relationship that is so important. And they're not, you're not looking at the back of their head while they're documenting in a computer because they've got to fill out all this paperwork for insurance companies.
Yeah, and we'd be remiss not to do a shout out to Dr. Tom Price, who was the former HHS secretary who served as our senior healthcare policy fellow on this project, and really provided years and years of input and experience into the development of the actual project and the output of the product.
Absolutely. Dr. Price was instrumental in bringing his experience and working with us on healthcare for you. I mean,
Yeah, invaluable actually.
yeah, I mean, he knows this stuff better than anybody, and so he
Yeah,
was just
absolutely.
great to work with. And now we're going to be joined by Dr. Molly Rutherford. I'm excited to talk to her. It's been a while. Dr. Rutherford is a family doctor. She's an addiction specialist, the wife of a law enforcement officer, mom of two boys, and self-described critical thinker. Molly, welcome to the show.
Oh, thanks for having me. I'm honored.
Well, we've talked a little bit about how we met you before you came on, but wanted to just talk to you a little bit about direct primary care and your practice and, how you got into direct primary care. What made you sort of move in that direction?
Okay. It's kind of an interesting story because as you know, I practice in Kentucky, and when I moved out here, I was working at a rural practice in Carrollton, and I was working for a hospital system, which was fine. It was great. I enjoyed the job. And I started treating addiction in 2008, after just learning how many people were becoming addicted to the opioids. And while I was doing that, I was trying to do it within the hospital system, but they didn't receive any reimbursement for those services. So when I went to try to expand the program, they said no, the hospital system basically said no. So I ended up working part-time for another company that was cash based. And all they did was addiction medicine. It was primarily buprenorphine prescribing for opioid dependence. So Suboxone was the brand name at one point. And I just really enjoyed that work. I realized pretty quickly that I was able to just focus on the patient, and I didn't have to remember all these billing codes. I didn't have to click a bunch of boxes to make sure that my employer was getting paid. And it was just a much better way to provide patient care. So I ended up taking another job with. I was still employed, but it was an independent practice, and it was what's called a patient-centered medical home, which started to be pushed a little bit before the Affordable Care Act came out, but after the Affordable Care Act came out, it was really pushed, and it was supposed to be an opportunity to, I guess, do capitation within these practices. Well, anyway, it was a nightmare. I had to see 30 patients a day. It was a big headache. I wasn't able to help anyone. I was bringing work home with me. I had two small children. My husband's in law enforcement, and it was just way too much stress. And I was having to do my charting at home, because when the electronic medical records came out, it was just a nightmare. So I happened to see a video of Dr. Josh Umber. I don't know if you're familiar with him. He started his direct primary care practice right out of residency out in Wichita, Kansas. So I saw him speak in a YouTube video about direct primary care, and I ended up reaching out to him and saying, "Hey, do you think I can do this?" And he helped me, and I'm so thankful. So I just discussed it with my husband, and I said, I'm not going to be a doctor anymore if I can't make this work. And we started the practice in 2015 in Crestwood, Kentucky, and it's just been amazing. And everybody benefits: my employees, myself, my family, the patients love it. So it's wonderful.
Tell us how it works. How does the membership or the how does it work from a patient perspective?
Well, the patients pay me monthly, so they pay a monthly fee. And this is where I think people get confused. They'll confuse direct primary care with concierge medicine, which they have similar goal. They have the goal of reducing the physician patient panel so that the physician can spend more time with the patient. The difference between direct primary care and concierge medicine is the concierge doctors continue to bill insurance. So they basically are charging a premium for access to the doctor. So they'll charge maybe $2,000 to $3,000 a year for this improved access, and then maybe some specialized testing. But then when the patient comes in, they still bill insurance or Medicare or Medicaid for the services. Direct care, whether it be direct primary care or direct specialty care, because I provide both as an addiction specialist. I provide direct specialty care. It's a monthly fee that covers various services. So my fee ranges from, it's $20 for a child, but we require a parent to sign up or a guardian to sign up, and then it ranges from $55 a month to $105 a month, depending on age. So it's sort of risk stratified, but that allows people to come in pretty much as they need to. There's no limit on the number of visits. And then we can seamlessly provide telemedicine services. It covers, I don't charge extra for an EKG, for example. If I were to bill for an EKG, if I were billing an insurance company, I could charge hundreds of dollars, but I don't charge extra for that. We don't charge extra for, say, a urinalysis, like if somebody thinks they have a urinary tract infection. We don't charge extra for a strep test. And then it also provides some access to me after hours for urgent concerns. So if somebody gets sick over the weekend, they think they have strep, they don't really want to go to the urgent care because it's expensive and maybe they don't really trust the care, then they can contact me either by phone or by text, and if need be, I can meet them here. During COVID, I met people in the office so many times on the weekends just to make sure that they were treated properly and didn't have to go to the ER. So that's an added advantage. And then in Kentucky, we're allowed to dispense medications. So I dispense medications, mostly generics, here in the office, and I'm able to save people money on those. There's a huge markup at the pharmacy on most medications, even generic medications, because of the pharmacy benefit managers. And then we also draw labs here. The labs are discounted as well. So a standard panel that we do for wellness is around $30, whereas if someone got that at a physician's office who billed insurance, it would be probably close to $1,000. I mean, it's really unbelievable how much money is saved for the patient, but also just for the system. So I just, really hope more people do this.
$30 versus $1,000. That's incredible.
Oh,
it's
crazy.
It's amazing, doctor. I mean, listening to you talk about this, it sounds almost like our entire healthcare system is like organized crime. The way it actually works, because I mean, people could really be able to afford medical care if they did more of this, I would think, versus our current system.
Absolutely. Absolutely. I don't know if you're familiar with Dr. Keith Smith, but he's one of my heroes. He started the Surgery Center of Oklahoma out in Oklahoma in the early 90s. And so he was really one of the pioneers, and he's been able to do this even with surgery and save people money. He saves people and businesses so much money that often it's cheaper for someone to fly out there to have an elective surgery rather than to go to their local hospital and have it done. I mean, you're exactly right. It's like a cartel. It's like organized crime. It's really sick how many people are just making money from all of the dysfunction. It's a very big game. I like to call it a game.
Yeah.
Yeah.
I mean, that's what was always really, I think, frustrating with the Affordable Care Act or Obamacare, is that it really didn't do anything to really address affordability.
No.
Yes, it expanded eligibility or coverage, but okay, so you can't afford it. I mean, so what good does it to expand coverage if you can't afford it?
Can't afford the coverage.
And so,
yeah.
Right, exactly. You can't afford it. So, I sit there and I want to ask the question of what's preventing this from really catching on and becoming a bigger thing. But I probably already know the answer is because this cartel won't allow it to happen.
Yes, I believe so. And I also think the cost of medical education, that plays a role in residents coming. I have residents who come here and rotate with me occasionally, and then I have medical students sometimes. And the debt that one accumulates in medical school is significant. And quite frankly, most of us who do direct primary care we just have an independent practice, one practice. There are some bigger companies that have scaled up and that's great. I have no problem with people doing that. That just wasn't for me. But they're when doctors graduate from residency, they're looking for ways immediately, for a good salary and then also for loan repayment. And many of these hospital systems offer a big chunk of cash towards your loans. I got
Right.
that. And so it's just more challenging to do this. It's possible, and I definitely encourage people to do it because I feel like if you never get into the game, then you don't have to reach that level of burnout that forces you to make a change. You can do things, you can be a real doctor from the get-go, because I don't feel like many of my colleagues who are stuck in the system feel like they are practicing medicine. They are working for someone else, checking boxes. They have no autonomy, and it got even worse during the pandemic because people were told, you can't prescribe this, you can't prescribe that, you have to wear a mask. I mean, up until I think a couple months ago, the hospital systems in my area were still requiring doctors to wear masks. And yeah, and many people lost their jobs because they were forced, they were told they had to get the shot. So um, there are many obstacles to young doctors doing this, and then also just getting the word out, because it's we're not really invited in. I was invited to University of Louisville, and I gave a talk at the University of Louisville about direct primary care, but very rarely are we, they're not enthusiastically coming to have us, give grand rounds or give talks on this type of practice.
Why do you think that is?
There's one misconception that we can't take care of, or that poor people cannot afford direct primary care. So that's the big question. What about the poor is what often comes up. Well, how does this help the people with Medicaid or who can't afford your services? Well, most direct primary care doctors do take Medicaid patients, and the Medicaid patients can afford the care. In fact, I have several. In Kentucky, it's a little bit harder to do because um, our governor several years ago passed a law sort of making it illegal um, to charge cash to a Medicaid patient if you have a Medicaid number. Now, you can get around that by just dropping your number, but then there's an issue if I have someone who needs a referral or needs a medicine that I don't have in stock, then it's not covered. You see, so but in most states that's not a problem. So I'm right on the border of Indiana, so I'm signed up with as an opt-out physician with Indiana Medicaid, so the patient still pays the monthly fee, and they, if they need a referral or if they need a brand name medicine, it's covered for them. So I think most states except for Colorado and Kentucky, you're able to still help people with Medicaid. Now, of course, there are going to be people who are extremely poor who maybe cannot pay that fee. And as independent, as independent physicians owning it, I own my practice. If I want to help, if I want to discount that amount, I can discount that amount. Or if someone's going through a hard time, I had a patient who didn't have a job for a few months. I just we come up with a billing plan, or I waive their fee for a couple of months. I can do that. Whereas in the system, I couldn't even tell a patient, you know what, I'm going to waive your copay today because you're going through hard times. That was considered fraud. If you're within the system, if you're within the game, I wouldn't have any power to do that.
That's truly amazing. Unfortunately, I understand, Dr. Rutherford, that independent physicians, basically, that aren't part of a big system, you're down to about, what, 35% of the doctors out there are really independents. Is that correct?
For primary care, it is probably even less than that.
Wow.
When the systems were already buying up primary care practices prior to the Affordable Care Act, but once the Affordable Care Act kicked in and these practices were required to purchase these huge electronic medical record systems, very few were able to continue to be independent. They all sold out. Even my employer that I was telling you about, who had remained independent and was trying to become a patient-centered medical home. Once after I left, he ended up selling his practice to a big hospital system too. So other than direct care practices these days, I can't think of any that are freestanding that are still billing insurance. Maybe John Littell in Florida. I think he's still independent and he's still billing insurance, but for the most part, it's very rare for primary care. We just can't stay open.
Right. Right. And it was really the electronic medical billing system that caused. Is that related to HIPAA?
They I believe they became mandatory as part of the Affordable Care Act. I don't want to
Oh, okay.
misspeak, but
Okay.
I believe so.
Okay.
And I think it was tied to, of course, tied to the behemoth Medicare program that,
Right.
if you wanted to continue to get money from Medicare, you had to do this. It's always that, I don't know. It's I don't know if it's a carrot or a stick. I guess it's both, but
It's more like a
it's
carrot
like,
and a bludgeon.
yes,
Exactly.
yes.
Yeah.
Well, I spend a great deal of time educating and talking about my experience with direct primary care with friends and pretty much anybody who will listen, because I do think it is a lot of what you said, is that getting the word out about what direct primary care is and how it can really help you get back to that doctor-patient relationship. And I'll just share with you real quickly. As you know, I've written about my personal experience. I have a strong history of breast cancer in my family with a grandmother, my mother, and my sister. And so 2 years ago, I inquired with my, insurance-oriented doctor as part of a big system about additional testing to, make sure that I wasn't, missing something in just my regular mammograms. And the doctor wrote on the mammography prescription as needed. And so that radiologist ordered an additional test 6 months later instead of immediately. But it's because the radiologist didn't know my history or anything like that. And I was very frustrated because I just lost my sister and I needed some insurance, insurance in my head, not real insurance, that I wasn't missing something. And so I knew about direct primary care because of my work with you and other and Physicians for Reform and our healthcare plan, Healthcare for You. And so I sought out a direct primary care doctor. She prescribed the additional testing immediately, along with genetic testing, which ultimately resulted in a preventative double mastectomy. And I don't talk about this a lot publicly, but I think it's so important for people to understand because I achieved all of that before the 6 months was up that original radiologist said, let's do the second test then. I had my genetic testing, I had my double mastectomy, I had my reconstruction, I was healed, and I was out running 5 miles 3 times a week again by the time that 6 months rolled around. And so the time is so critical when you're facing something like that. And so I always tell my friends, I'm a previvor. I'm not a survivor of cancer, but I'm a previvor of cancer. And that's how I talk about direct primary care, is that I was able to work through the system and not have to wait like insurance and the doctors, that their automatic response is delay, 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 delay. And we see it in other countries. I mean, there are year-long waits and millions of people on wait lists in Canada and the UK. We're going to be there someday if we keep going down this path. And so I try to help people understand how this system, I believe, may have saved my life.
Absolutely. We are there. I'm seeing it now just with trying to refer patients for specialty care not necessarily for cancer care. Usually I can get on the phone with somebody and get a rush on that, but there seems to be, 4 to 6 months wait for people to get their initial visit with specialists. And so, we are there. And part of it is also there are everybody within the system is practicing this guideline medicine. And when you put a diagnosis in, there's a code with it, and everything that you order you have to justify with some code. And since I work with independent radiology, they don't ask for that because the patient is usually paying cash for the study. And most of those studies are very, like a mammogram would be, I can't think of, but $100, $150 for a 3D maybe. So it's much more affordable. But you're exactly right. Thank God you knew what you knew and were plugged in to this sort of, I guess, alternate system that we have. Because I don't know how long it would have taken you to get in with someone if you'd gone through that whole process.
How do we marry up, in addition to sort of marketing this, but how do we marry up the demand with the supply, or the supply with the demand? Because it's kind of like, what comes first, the chicken or the egg, right?
There are some good companies working on that. One is Hint. I don't know if you've heard of them, but they're helping create sort of a marketplace, I think, of direct primary care physicians. And they are working mainly with employers because, unfortunately, I'm not a big fan of it, but the reality is most people get their coverage through their employers. So one of the really wonderful, optimistic, I would say, when I went to the Free Market Medical Association meeting out in Kansas City in May, some positive news was that there are more people entering this space to try to make it easier for patients to find doctors like me and Kat Lindley and Dr. Keith Smith and Josh Umber. And then there are these new types of brokers that are working with small businesses, larger businesses, to try to educate them as the provider of the coverage on how to reduce their costs on coverage by finding free doctors to provide the care. There was one individual who spoke. He's with Human Resources with a big company up in Wisconsin. I can't remember his name, but I can send it to you later if you're interested, because he'd be a good person to interview. He was able to save his company millions of dollars by helping with basically directing employees to free doctors that aren't impinged by the system. And Lee Gross, do you know Lee? I don't remember if he was part of it. Okay, same with him. He'd be a great person to interview too, because he's been very successful in incorporating even hospital care as part of a plan, what we would call a health plan for a company. I think it's a resort down in Florida, and he's documented even the results. He has data on how actual health outcomes have improved among those people who participated. So it's going. It's a slower, I think it's slower growth than many, I would say, business opportunities, but people are interested. They get it, especially people like you who have utilized the services. They're big fans. So look into Hint. And then we have an organization called the DPC Alliance that is helping to drive interest in direct primary care specifically. And they offer trainings, like weekend trainings for doctors who are interested in starting a practice. So there's several avenues, kind of branches, that are trying to get the word out and help more young doctors do this.
I'm curious, is this actually being taught in the medical schools, this concept?
I doubt it. I met a few medical students at the Free Market Medical Association meeting. They were from Oklahoma, and it sounded like they knew of the model from other avenues, not from school, so to speak. They're members of the Benjamin Rush Institute. Benjamin Rush has chapters at most medical schools, and they're more focused on free market medicine and the Hippocratic Oath and sort of medicine being what it used to be. So they learned about it through that, and I think it's going to be harder for students to learn about it. The medical schools are big indoctrination camps now. It's pretty scary.
Right. Yeah,
So
I've heard that they have entire courses on literally just how to code.
yes,
Um,
that and then other social issues too. We won't get into that, but it's just, I mean, it's kind of frightening what's happening to the profession. Um, yeah, so I hope I hope more people learn about it, and then I just want for the audience, I'm available for medical students, pre-med students. I had a pre-med student come and spend a couple days with me recently. Anyone who would want to do a rotation here, we could make that happen.
I mean, that would be phenomenal. I mean, we have to be able to get the word out. I know Lee has done a great job. League Res has done a great job and the Alliance. But we do have to do more because it is quite the system that you're really fighting. When you're talking about less than 30%, maybe 25% of all doctors, primary care doctors being independent. I mean, it is really an uphill battle, but we have to push back. We have to fight back because the system's not getting any better. It's gotten worse since the beginning of Obamacare.
Yes, it's gotten worse, and I think one silver lining is I believe much of it was exposed for what it is. The system was exposed for what it is during COVID. And so there are so many patients looking for free thinking, critical thinking physicians who are not part of the system, who are not going to just parrot a narrative, like, oh, you need these 5 shots today, and if you don't get them, you're not going to be my patient anymore. People are, fed up with that, and I think that it's a good opportunity for people who want to make the switch to this type of practice to do it. I think they're more likely to build quickly. And then it's a great opportunity for young doctors who really want to be doctors, who want to practice medicine and not just check boxes and collect a paycheck to get started in that direction.
Dr. Rutherford, we've got a couple minutes left, but I wonder if you could take a couple minutes and talk about pharmacy benefit managers. I mean, we hear politicians like Bernie Sanders, talk about the evil pharmaceuticals and the cost of insulin, and President Biden talks about how they've brought the cost of insulin down and other drugs and through price controls. Talk about pharmacy benefit managers and how that impacts things. I know you've written about that in some of the op-eds that you've written as well.
Yes. So basically, they get a cut of the pharmacy benefit managers. They're usually an extension of the insurance company and or of the pharmacy. So what happens is if you're at your doctor and they write a prescription, say for a generic medicine, such as, I'll just use an example of something that's used frequently, lisinopril, which is a blood pressure medication. I have that in stock here for pennies. So if I were to dispense a 30-day supply of that medication for someone with maybe a 15% markup to pay for my labels and my bottles and everything, labor, it would be, a couple dollars for the whole month. Well, the pharmacy benefit managers, they get in a room with the pharmacies. It's all these backroom deals. And what happens is they say, okay, we're going to make the copay on this medication $20. Well, these days, most people don't think $20 is a big deal to pay for a medication because there are medications that are hundreds of dollars. And so the patient just automatically pays that thinking they're getting a good deal. Or even if it's $10, it's still a huge markup compared to the the actual cost that the pharmacy is paying for it, because I'm sure the pharmacies get those medicines even cheaper than I do. And then the amount that is left over gets split between the pharmacy and the pharmacy benefit manager, I believe, if that's, or maybe it all goes to the pharmacy. Anyway, the bottom line, I guess, is there's this middleman inserted in claiming to have value, but really they're just extracting money from the system and keeping it for themselves. So, and the other thing that they do, which is awful, is they tell patients where they can get their medicines, where they cannot get their medicines, or they won't pay for it if you don't do mail order, for example. So there's no freedom really in terms of where the patient can get the medication. So it drives up the cost of the medications ultimately. And it's just another layer in the system that we don't need. It's another part of I'm trying to think what part of the organized crime they would be, but I should ask my husband. He's in law enforcement. He would know. But yeah, it's just it's a hassle. They're not really making things easier for the patient. They're not making things less expensive.
Those are the kickback laws the anti-kickback laws that we need to get rid of, right?
Correct. Yes. And there are several people working on that. And, but it's a battle because there's so much money. And as you know, they lobby. So, they lobby all of these people in Washington, and it doesn't seem to matter which party. They tend to get their way, and that's the nature of politics, I guess, in the United States right now.
Well, I've read it's $250 million a year, so that's why they're fighting so hard to keep it, because it's a lot of money.
It's more like 250 billion, you mean, not
million. Billion, sorry. Millions, billions.
Wow.
It's all monopoly money. It is billion,
Yeah.
You're right.
Well, that's the thing. If you think about it, the PBM industry as a whole effectively didn't exist before Obamacare.
Right.
I mean, so you went basically in a matter of 15 years or something like that, from zero to 250 billion. And that's not savings. That's just additional cost to the system, really, because the PBMs have no incentive to actually save money, because they actually get effectively a percentage off the retail list price of the medication.
Correct.
So they want to inflate it, not deflate it.
And they do. Yeah, that's exactly why so many of those medicines that have been around forever, that should be affordable, such as insulin, are no longer affordable. So.
Well, Dr. Rutherford, do you have a website that for your practice, that if somebody wants to go to your website and get more information, they can?
Yes, my website is bluegrassfamilywellness.com, and I am on Twitter, Instagram, and then I have a Facebook account. They're all at Unbridled MD. So
excellent.
Yeah, they can find me there. I have a Substack. I don't write very much. I don't really have time, but I'd like to write more. I have a Substack also.
We'll also put the information for Lee Gross and his organization out on this as a link.
Yes, his is he has a new one, I think, called the U.S. Medical Association, and then there's also DPC Alliance, which is separate. I'm not sure if Lee is a member of that, but it's another organization to help specifically for people who want to do direct primary care. And then the Free Market Medical Association and the AAPS, which is the Physicians and Surgeons American. I don't want to mess up the acronym, but AAPS Online is on Twitter. They are the free doctor group. So any doctors who just don't know where to get the information, join the AAPS for sure.
Well, Dr. Rutherford, thank you so much for joining us today. We love your perspective, because you come to us not only to talk from a small business owner perspective, because you are an entrepreneur, but also from the healthcare perspective and helping people understand this alternative way that I believe in personally, and I think could really change our healthcare system in this country. And thank you all for joining us on Main Street Matters, America's small business megaphone. You can subscribe to our show at salempodcastnetwork.com. We have new episodes every week on Wednesdays and Thursdays.